Namaskar. Welcome, dear colleagues, to today's Young India Intensive webinar. And today is a very important topic, something very basic, that is recording of vitals. But if we don't get it right, we are going to interpret them wrongly, and our data collection is going to be wrong. So it's very important to understand the ways, different ways which we can record, and what are the pitfalls. So we have a very nice speaker today. The ma'am is Dr. Sulagna Bhatacharjee, and she's done a DM critical care from All India Institute of Medical Sciences, New Delhi, and she is now the associate professor in the same department. And she has a remarkable career in a very small time frame. She's been, awarded with several prizes. She's won the Presidential Citation Award 2023 by ICCM. So that is really remarkable at such a young age. And then she's also got the Department of Science and Technology SERB Earlier Career Research Award. Then she's got a short-term fellowship for medical research and practice to France by French Institute of India. And she's also a fellow of French Institute of India. So really remarkable, ma'am, for such a young age. And we wish you all the best. And we look forward to your talk. Over to you, ma'am.
Thank you, sir. I'll just share my. So, good evening, everyone. My today's topic is recording of vitals, methods, and pitfalls. I have mainly focused on the systems that are used to record vitals. I can also, maybe if you feel it is incomplete, then I can also talk to some length about the basic ways that we measured the vitals. Let me first present my slides. So why is it important to monitor the vitals? Just one. So most critically patients admitted to ICU or developing cardiac arrest, cardiopulmonary arrest have detectable signs of deterioration earlier in the ward or in other clinical areas, which are missed. It has been seen that more than 80% of these patients have detectable signs of deterioration in the previous 24 hours, which are not adequately picked up by the caring team. This is mainly due to a lack of knowledge and skills, lack of recognition of clinical urgency, and failure to seek advice in time. So, yeah. So, in a multi-hospital review, in a multi-hospital survey in Australia, when it was seen that how the practices of documentation of clinical review and vital signs were done after major surgery, it was found that during the first 3 post-operative ward days, only 17% of the medical records had complete documentation of vital signs and medical and nursing reviews. The first 7 post-operative days had undocumented a good extent of patients. Their vitals like 5% and 14%. They didn't have reviews. Respiratory rate was the most commonly undocumented observation. Vital signs were more commonly undocumented in patients who did not have epidural catheters during night shift, during successive postoperative ward days. And nursing review was more commonly undocumented in the evening and medical during the weekends. So what are the vital signs that we need to measure? According to the Australasian College, they define the vital signs that need to be adequately monitored are like the level of consciousness, respiratory rate, oxygen saturation, heart rate and blood pressure, temperature, and in most cases, according to the clinical scenario, pain and capillary refill time. So these have to be measured, documented, tracked, and monitored to get any to make any fruitful decisions. Now, in the emergency patients, how often should we measure? It should be during each shift, in the emergency after presentation, at least one set of vitals should be measured. They can be more frequently measured in high-risk patients like infants and pregnant patients. And they should be appropriately displayed graphically with the intervals. And the monitoring and pre and post intervention should be decided based on the values. And it should be complemented with point of care testing and assessments at periodic intervals, as clinically indicated. Now, the National Institute of Health and Clinical Excellence in 2007 had come up with guidelines for response to acute illness in adults admitted to hospitals. They advise that initial assessment and part of routine monitoring must include heart rate, respiratory rate, as we already mentioned, systolic blood pressure, level of consciousness, temperature, and oxygen saturation. Also, the monitoring plan should be catered to the diagnosis of the patient, the presence of comorbidities, and the presence of and the agreed treatments, the treatment plan that has been decided after medical review. So, vital sign monitoring should be done with physiological track and trigger systems. Now, what are these? These are warning systems. These are widely used in countries like UK, Australia, in other European countries like Netherlands, Denmark. It identifies patients in general wards at risk of deterioration. The periodic observation of selected basic physiological signs with predetermined calling or response criteria is central to the use of warning systems, and it helps in monitoring a large number of patients without increasing workload for the nursing personnel. So what are the different types of track and trigger systems? The first and the foremost, which the initial ones that were used were the single parameter systems. Now, these included periodic observations of selected vital signs that were compared with a simple set of criteria with predefined thresholds. And the response algorithm was also very simple. So only when any criteria was met, the alarm system was activated and there was a review by the caregiving team. Multiple parameter system came as a next modification. It consisted of algorithms which requires more than one criteria, and there are a number of multi-parameter systems, and it helped in although they did not have any scores, or they did not have any weights to the parameters, they helped in identifying the deterioration signals with with multiple parameters. So next came the aggregate scoring system. They were developed from weighted scores, which were assigned to physiological values and were compared with predefined trigger thresholds. And the last came the combination system, where a single parameter or a multiple parameter systems were used along with aggregate weighted scoring systems. We will come to these later. So the track and trigger systems that should be used are the multiple parameter monitoring systems, and it should have definite parameters, definition of the exact parameters, and also it should define the frequency of measurement, and the explicit cutoff points and the scores that are thresholds to elicit emergency response should also be defined. So if we compare the systems, the single parameter systems are simple and well reproduced. However, disadvantages are that they cannot track a patient's response. It does not allow a graded response. So if there is a deterioration of a particular parameter, it does not give any idea of how much care or how much attention or how much intervention to be done for that particular response. They have a very low sensitivity, low predictive values, and are not widely adopted in UK, but they definitely pave the way. Coming to the multiple parameter system, they allow monitoring of clinical progress, allow graded response, and are widely adopted, but they lack reliability and reproducibility due to human errors, because a lot of human effort needs to be put to interpret these multiple parameters. And they are not so sensitive because they need multiple parameters. So all parameters may not be present at the same time in a deteriorating patient, and that may be missed. Coming to aggregate scoring systems like the early warning signs and the modified early warning signs, they allow monitoring of clinical progress, they allow graded response, and are widely adopted. However, similarly, they are prone to human errors and lack reliability, and their sensitivity and specificity can depend on the cutoff used. We will discuss it in a bit detail later on. So coming to how will the uh, team, the nursing team or the caregiver team outside the ICU or acute care areas respond to um, uh, uh, these vital signs deterioration from the different scoring systems or the uh, parameter systems. So once there is a risk of deterioration which is identified, the the nursing team will alert by a track and trigger score and will let the clinical team know about the clinical concern. So if it is a low score, then the frequency of observations can be increased and the nursing in charge can be informed and alerted. If the score is medium, then the primary medical team of the patient should be informed and called for. And also specialized teams like critical care outreach team should be contacted to in case there is a need of any intervention. And if the risk is high, then critical care practitioners or patients with advanced airway management skills like anesthesiologists should be called for, and an immediate response should be elicited, and the patients will need to be shifted to areas like the ICU. This is also true when in a clinical emergency where the patients are coming in and are getting admitted to dead areas. And a management plan should be formulated, including the location and the level of care required. So one of the earliest single parameter system that was used was the Liverpool Medical Emergency Team calling criteria. As we can see here, these are criteria which are based on intuitive ideas, and these were not backed by evidence generated by physician. They were mainly agreed upon by nursing personnel and nursing care teams, and it was really interpretation of these parameters was really subjective and was definitely prone to a lot of errors. One of the widely used systems, single parameter system, was the medical emergency team system, which had components like airway, breathing, circulation, neurology, and others like some biochemical or laboratory parameters available at the bedside. So the MET system could increase the emergency team calls, but it did not affect did not reduce incidence of cardiac arrest or unplanned ICU admissions or unexpected deaths. So it was not suitable. Second came one of the widely used multi-para systems like the PART system, patient at risk alert systems. So they, again, this was this did not come from data, but with the parameters were mainly intuitive idea based and nursing experience based. So they also had a low sensitivity and specificity, but this included multiple parameters like the temperature, BP, heart rate, etc. So and both sides of the median range were studied properly. So it definitely had a better performance than the single parameter systems. And up till up till 2 decades, it was used quite widely. Next comes the aggregated weighing scoring systems. Now, these are made by allocating points according to the degree of derangement of physiological variables. Then these points are combined into a composite score, and they are compared with trigger thresholds. So the trigger thresholds are devised, they are described, and when these trigger thresholds are reached, the alarms are generated. So the teams are supposed to inform the medical personnel, and depending on the score of the patient, the grade of medical intervention that is required, if the patient requires ICU care or if the patient requires uh, a small intervention in the bedside, that can be decided. So one of the widely used aggregate scoring systems are the modified early warning score, which, as we can see in the screen, has these parameters like systolic blood pressure, heart rate, respiratory rate, temperature, and AVPU score. AVPU is the score for assessing level of consciousness, and the scoring system is given based on the severity of the derangement of physiological parameter. The other different input and output variables of early warning scores, like the views, which has been used in ICU, medical ward, surgical ward. The input criteria are almost the same. The news and news 2 have been used also during the COVID-19 pandemic. And for pediatric patients, we have the PU score, and the TRU score is for emergency department trauma, where age is also included. So what are the strengths of early warning scores? The strengths are that they can accurately predict adverse outcomes. They can have excellent predictors of cardiac arrest, ICU transfer, and ICU and 30-day mortality. They can be used as triage instruments in the emergency department. They can prevent ICU admission by aiding decision making. Improve patient care outcomes like survival to hospital discharge. It has been observed in hospitals which have implemented these early warning scores, and they can be used cross country in different populations. Although the sensitivity and specificity may vary between country to country and from population to population, but their use has increased in the last decade and has actually benefited the different populations. So what are the limitations? They can be these early warning scores may have a low specificity depending on the patient population and the geographical location. They need a lot of practitioner engagement, because it has been seen from surveillance data that although these scoring systems are even after implementation for a long time, many patients in situations like the wards or in the emergencies, there is a lot of missing data, and there is need for clinical judgment is also another cause of concern, because even when the scores are met, the time to respond to them from a medical the vitals of the patient. So, and it requires intermittent so the if something happens in between, it may not be picked up at the golden hour. This is one of the combination systems. A combination system is with aggregate weighted system with a single parameter or a multiple parameter. This is developed in Australia, in Queensland, and it is called the adult deterioration detection system. So if we see that there is these are the chart for documenting the scores of the different physiological parameters, and there is also a single parameter scoring system where if any of these are met, any of these conditions are present, then the practitioner can directly go for intervention without waiting for the total score. So this is a fail-safe mechanism, so that if the total score is not calculated properly, or if it is not available because of non-availability of one or more of the physiological parameters, then one can directly use this and go for immediate medical intervention. So here, as we said, that the total score is set for the vital signs, and a single track and trigger system also allows intervention independent of the total score. So coming to our the latest innovations in vital sign monitoring is automated continuous non-invasive ward monitoring. Here, as we can see, in an intermittent spot check, a patient's physiological derangement may be missed. So if we have a continuous monitoring, then it will alert the nursing team from the bedside. The nursing personnel may not be available at the patient's bedside, but the information and the alarm system will be delivered to the nursing team from the automated device, wireless device, and this can help in early recognition and intervention. However, these systems have to be meticulously validated with regards to their performance. Minimization of artifacts and false alarms is a concern, because uh, uh, the sensitivity and the specificity of the thresholds may lead to a lot of false alarms and a lot of unnecessary engagement from the treating team. Integration and combination of these systems require a massive amount of data, and which need to be analyzed. So the systems and the hospital information systems has to be they have to integrate it to the existing systems, and technical problems like the connectivity, like internet availability and all, have to be ensured. So if these are the future of our vital signs monitoring, and many devices have come up. Of one of the published studies in 2017 saw the effect of an automated notification system for deteriorating ward patients on clinical outcomes. So here about more than 2,000 patients were included, and by deploying these rapid response, by deploying these automated devices, the rapid response teams had the notifications of RRT teams had increased considerably, and it also lead to a decrease in mortality and decrease in the number of cardiac arrests. So they uh, they concluded that deployment of an electronic automated advisory vital sign monitoring notification system to signal clinical deterioration in ward patients was associated with significant improvements in key patient-centered clinical outcomes. We can see that this is the monitor, and these are the parameters that have been studied at frequent intervals. And this is like a patch that has been attached. And this is another device that is integrated to monitor the SpO2, the pulse rate, and also the blood pressure. They can also measure the temperature and the humidity. So all these multi-parametric monitoring at the bedside, and whenever there is a significant clinical deterioration in the parameters, the nursing team will be alerted at the bench side. So this definitely a number of systems have come up, and they are being widely used. So this is the future of vital monitoring. So
Have you finished, Dr. Sulagna?
yeah, I've finished, sir.
Okay, okay. So just close the share screen.
Yeah.
So maybe we can just discuss a few things, Dr. Sulagna. You told very nicely about all this. But coming to a little about the practical aspects, so
Yeah.
so
Sir,
within the,
actually,
yeah, follow, carry on.
uh, can you see my screen?
Yeah, no, screen has gone. We can see you.
Yeah. Okay, right.
So we just discuss a couple of points for the audience.
Yeah, sure. So
So
if hmm,
yes, you are saying something.
yes, sir. So if we come to these basic vital sign monitoring like the heart rate, so heart rate is one of the primary monitors that we see in ICU. We get heart rate both as a pulse rate and as a heart rate from the ECG. So heart rate, uh, definitely tachycardia and all are, I mean, these are commonly encountered, the tachyarrhythmias and the bradyarrhythmias. One important thing is that we generally do not see the ST depressions or the ST changes. We may not be able to appreciate them. So in our multi-para monitors that we have at bedside, so bedside ECG at frequent intervals when required should be done. We sometimes tend to miss those things. And so coming to pulse oximetry is measured by infrared technique. So there are two wavelengths of light that are emitted from the photodiodes in the pulse oximeter, and there is a sensor which receives those the absorb. It receives uh, the light which has not been absorbed. So the absorbed light determines the level of saturation. The light is absorbed, one part one part of it is by the pulsatile flow of the blood, and the other part is by the non-pulsatile flow of the blood. So this the pulse oximetry therefore works in a real time. However, it has a lag time of around 1 minute. So if a patient has already started hypoventilating and getting hypoxic, we may not be able to appreciate the SpO2 change before 1 minute. So once the patient saturation starts falling from 100% to 98 to 95, we should, if we are in the middle of any procedure like the fiber optic bronchoscopy or intubation or some suctioning or lavage like that, so we need to stop our procedure and we need to again oxygenate the patient, because by the time the pulse oximetry is showing 95%, already the saturation has gone down. The PO2 has gone down to below 80. So also from pulse oximetry, we get some other information like the perfusion index, which can be used as a marker of fluid responsiveness when used alongside with
Uh,
other
just add
interventions.
to
Yeah.
the pulse oximetry, very basic thing, since we have a lot of young people. You have to get a proper waveform. If you are getting a undulating kind of a waveform or there's no waveform, then the pulse oximeter reading is not
Yeah.
reliable.
Yeah. So
It's a very big problem. This is a very common
yeah.
problem.
Yeah, so the pulse oximetry should have a number and a proper waveform. Without a waveform, if there is a number, we should not consider it to be a proper reading. It is just a false reading. So without a waveform, the number does not mean anything. And pulse oximetry is a very important monitoring tool, and it should be used during all our procedures, like when we are intubating a patient, when we are putting NIV, or when we are giving oxygen. So it is very important that we continuously monitor the pulse oximetry. Sometimes when the patient is not warm, there is peripheral hypothermia. So the pulse oximetry may not show at exact values, or it may not show values at all. So that has to be picked up. And if a central uh, uh, the pulse oximeter can be attached to a more central area like the pinna of the ear, or maybe the nasal ala. Or there's also a technique of, there's also a device to attach the pulse oximetry probe to the forehead, which is relatively spared in peripheral hypothermia. So the site of um, monitoring of pulse oximetry is also important. And all sometimes we need to monitor in ICU. We may need to monitor the oximetry at two different sites. Like if the patient is having any uh, any obstruction to blood flow at any point. Suppose the patient is having thrombus in one of the arteries, or there has been a surgery, thrombectomy, or some procedure has been done in the subclavian artery. So then we should monitor the pulse oximetry at uh, that particular arterial circulation as well. And if we don't have a pulse oximeter reading, then we should check the PO2 levels by an ABG. Also, there is a device called Masimo, which utilizes more than two infrared wavelengths. It uses 8 wavelengths, and that can help us in detecting carboxyhemoglobin, methemoglobin, and fetal hemoglobin, along with our oxyhemoglobin and deoxyhemoglobin. So along with normal hemoglobin, if we use more wavelengths, then the absorption spectra of the hemoglobin, abnormal hemoglobin levels can also be picked up. And this is a form of advanced pulse oximetry, which gives us information. Suppose in carbon monoxide poisoning, that can be useful. Or in inhalation burn injury patients, that can be used. So, like that, then we may come
Then,
to,
Sulagna, about temperature. Temperature is a big problem because auxiliary is
yeah,
inaccurate. I know.
yeah,
Just talk about the temperature, guys.
yeah. So, our idea is to maintain, to get a temperature as close to the core temperature as possible. Now, the highest temperature is in the body is at the level of ascending aorta. So, but we obviously we can only measure that something very close to core temperature when we put a pulmonary artery catheter. Otherwise, we cannot measure the temperature of the central core temperature of the body from the blood. So we use other surrogate markers like the cutaneous temperature. Now, cutaneous temperature is around 1 degree to 2 degrees Celsius cooler than the core temperature. Cutaneous temperature can be attached at the axillary side, but the problem is advantage, it is non-invasive, it is easily accessible, and it does not carry any risk of infection to the patient from the device. But disadvantage is that it definitely will not be able to pick up. If the patient has peripheral cooling hypothermia, the central temperature may be relatively spared, but the peripheral temperature is very down. So we don't get an idea of it. This is important in areas where we need, suppose we are instituting hypothermia in the patient in a post-cardiac arrest scenario. If we need to give hypothermia, then accurate monitoring of temperature is very important. Also, if the patient has very high fevers and there is a lot of sweating in some poisonings like the atropine poisoning or atropine-like substance poisoning, when there is a lot of fever. So in situations where there is along with fever, there is sweating, the temperature probe may not work properly. Also, we can get skin temperatures with infrared scope probes, which can only, it's like a gun which has to be held. We usually hold it over the forehead, and we just shoot a ray of infrared on the forehead, and when the infrared ray comes back to the sensor, and the difference in absorption from by the patient's body gives us an estimate of the patient's temperature. Now, this is again not very reliable, because again it depends on if there is any sweat on the patient's skin and so on. So coming to when we cannot go for the core temperature, we can go for other temperature measurement areas like the tympanic membrane, like like in the rectal temperatures, or in the nasopharynx or oropharynx. Now, nasopharynx among them is very near to the behind the nasopharynx are all the major vessels, some of the major vessels. So it's very near to the aorta. So it can pick up it has good correlation with the core temperature. Tympanic membrane also again has good correlation, but it is not as sensitive as the nasopharyngeal. It can be around 0.5 to 1 degree Celsius less than the core temperature. Rectal temperatures may vary. It can give erratic readings because the blood subrectum is not a very highly vascularized organ. So the temperature may differ depending if the patient is in shock, then the splanchnic circulation is reduced and the patient and the temperature from the rectum may not be very accurate. Other than that, you can measure temp as I think I have mentioned that if we put a pulmonary artery catheter, then we can measure temperature from the pulmonary artery itself, which is again can give a accurate estimation of the core temperature.
So, in
Yeah.
your case, you for routine measurement using auxiliary measurement?
No, sir. We mostly use nasopharyngeal temperature probes if it is feasible, if there is no coagulopathy or if there is no obstruction locally. But we try to use either nasopharyngeal or oropharyngeal. Axillary only when we don't, maybe we at situations we don't have a probe or uh, I mean, otherwise the patient, we don't want to put a nasopharyngeal probe or the patient is awake. Only then. In awake patients, we usually take intermittent temperatures. But for continuous temperature measurements, we prefer nasopharyngeal or oropharyngeal.
So for hypothermia, nasopharyngeal is good, right? It is almost like core
Yes,
temperature.
yes, yes.
Okay, great. So let us move on to non-invasive blood pressure measurement, accuracy. So can you talk a
Yes,
little
yes.
about that? Tell the audience.
Yes, so non-invasive is we measure non-invasive blood pressure by a technique called oscillometry. Now here, the once the cuff is inflated, the cuff is gradually deflated, and the maximum the maximum pulse volume, when the maximum pulse volume is felt while at the time of deflation of the cuff, when the cuff is gradually deflated, then at the maximum pulse volume, the mean arterial pressure is recorded. And when this maximum pulse volume comes to around 25% of the baseline, then the diastolic pressure is recorded. The systolic pressure is recorded calculating the based on, so mean arterial pressure is the most sensitive derivative that we get from the oscillometry, and the rest are calculated mainly from the from calculation of formula. From formula. So most accurate is mean arterial pressure. Diastolic blood pressure is the most inaccurate, and NIBP can suffice in patients who are not critically ill, in not having shock, so not on vasopressors. But patients on vasopressors have a lot of peripheral vasoconstriction, and this may be not accurate in, usually they are not accurate in such patients. They also have NIBP, if we are
Also, in hypertensive elderly, they're inaccurate because of.
yeah, so yes, sir. So in hypertension, the elderly have isolated systolic hypertension commonly. So the diastolic again here is underestimated, or maybe, yeah. So that is a problem. And so in ICU, we usually do not, unless the patient is not having shock or having some other neurological cause of ICU admission, the peripheral perfusion is well maintained. Unless that is the case, we don't prefer non-invasive blood pressure monitoring. And depending on, based on non-invasive blood pressure monitoring, we cannot take any decisions also regarding our vaso escalation or de-escalation of vasopressor or regarding giving fluids. So we usually do not use that in our ICUs.
Okay.
And
Yeah, that's all right. So, Dr. Sulagna, what about invasive arterial lines? So there was a study in which
yes,
we saw that 30% of the arterial lines were showing inaccurate BP. Is that correct? Or have you read anything like that?
So, arterial line, we usually put arterial line in the radial artery or the femoral artery. So, mostly the radial artery is preferred because it is relatively, it's a peripheral artery which is easily accessible. It can be cared for easily, and the infection rates are also less in the radial side. Um, but however, arterial line gives a continuous invasive measurement of blood pressure. It gives accurate reading of the systolic, diastolic, and mean blood pressures. Also, by looking at the arterial line waveform, we can see whether the patient is having fluid responsiveness by measuring the pulse pressure variation or stroke volume variation. We can also see whether there is any arrhythmias which are affecting the blood pressure. Sometimes arrhythmias do not affect blood pressure and we may overlook, but if we have a good tracing of the arterial waveform, we can accurately identify and see the hemodynamic effect of the arrhythmias. But these arterial line needs to be maintained, and it needs to be uh, zeroed at timely intervals. If there is underdamping in the system or overdamping in the system, then the arterial readings will not be accurate. And uh, also, we should also check whether it is blocked or not. So sometimes the arterial waveform gets missing, and although we get a mean arterial pressure reading, but that is not accurate. So proper maintenance of the arterial line and monitoring whether the all the components of the system of arterial pressure transducing, those have to be maintained in a proper way. So yes, in those cases, it can come inaccurate. Also, in sometimes when the patient has a very high dose of vasopressor, then the arterial waveform in the radial artery may not be accurately depicting the central blood pressures, the blood pressures of the central arteries like the femoral or the aorta. So, in that case, the femoral arterial waveforms are more accurate. In cases of cardiac surgery, we have seen that we take more central arterial readings like the femoral artery, so that the decision to give vasopressors and decision to put the patients on or wean from the patients from cardiopulmonary bypass or ECMO becomes easier. So those are the scenarios where peripheral radial artery reading may not be accurate.
Yeah, so also, with as you move away from the aorta to the periphery, the systolic increases, the diastolic decreases, the pulse pressure
Yes,
widens.
but the mean arterial pressure remains constant. So that increase or decrease of the systolic or diastolic should not be much of a concern, because in our resuscitation targets are mainly based on mean arterial pressures. And once we have achieved resuscitation, we can go by not just mean arterial or systolic or diastolic blood pressures, but also by markers of peripheral perfusion, whether the how the organ functions have improved, whether the patient is producing urine, whether the lactate has reduced. So just this is a physiological variation that happens in the arterial tree as we go distant from the heart, from the aorta to the peripheral artery. But since the mean arterial pressure remains constant, so it is we should not try to treat the diastolic pressure here if it comes low.
Yeah. So, Dr. Sulagna, now this concept of increasing the systolic and decreasing diastolic as we move to the periphery is valid mainly for patients who have a normal physiology in the arterial system. So this was an article by Dr. Pinsky, and they did an experiment, and they said in the septic patients this is not true. In fact, it's the other way around. So any comments on that? Because the impedance and the compliance of the arterial system in sepsis changes actually.
Sir, I have not gone through the article.
All right.
But so I mean,
Yeah, that's okay. So I was just asking if you have read this. This is Dr. Pinsky's article, and he has made this very interesting observation, and
okay.
the experiment also he has laid out, because the compliance and the impedance, etc., of the vascular system changes in sepsis. So this is actually more for patients who have normal kind of a physiology. The vascular system is not affected.
Sir, as far as I know, I mean, I have come across nowadays diastolic arterial blood pressure has been very much in discussion because uh, patients who come with septic shock with a low diastolic
Leave as
blood
a
pressure
person,
have
yeah? Or leave as
have 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 a worse outcome, have more mortality, and targeting if so, even if the mean arterial pressures have been recovered, if we don't recover, if we don't increase the diastolic blood pressure, the organ perfusions remain suboptimum. So diastolic blood pressures should be definitely be targeted if they are still low, even
yeah,
after resuscitation.
what is now, you're very right. They are saying that if the diastolic pressure is less than 50, then immediate vasopressor use should be there. Or
Yes, immediate vasopressor use, and rather than just giving fluids, we should start early vasopressors.
yeah,
So
okay.
especially patients with diastolic blood pressure.
So moving on to urine output, input and output, a very key area. So,
Yes, sir.
you are working in the Premier Institute. How is the recording of input output? Is it accurate by your systems? Because we have a lot of problems in our ICUs.
Sir, so firstly, in our ICUs, mostly, I mean, if I'm honest, then many a times it is seen that exact hourly measurement is not available. So it may be sometimes 2 hours and then they divide it by two, so something like that. So exact hourly measurement and accurate and precise measurement is not is very difficult to obtain actually. And number two is um, for intake and output we don't consider the insensible losses. So whatever cumulative balance we get in especially patients having fever or patients having a lot of I mean, yes, so sweating or patients losing fluid from other areas like from abdominal drain or from soakage from abdominal wounds or some soft tissues. So those are not accounted for. So exact intake output definitely we are not getting. And yes, urine output is very important because or mostly more than 70% of our patients they develop AKI with sepsis. And the severity of AKI, one of the markers is a reduced urine output. So oliguric patients with oliguric kidney failure, acute kidney injury have worse prognosis than those without oliguria. So it is very important that we measure them and we kind of pick up when the patient's urine output starts falling. We go for tests like the Lasix challenge test that also helps in uh, assessing whether the patient will require hemodialysis or not. So yes, urine output, measuring urine output and meticulously
Actually,
measuring them is
even
important.
hourly is all right, but at the end of the day, you need at least in the morning rounds to a correct 24-hour input output, which is not available at
Yes.
least in our hospitals. You are working in the Premier Institute because there's so many calculate output is still okay.
Yeah.
The input,
Yes.
there's so many fluids are going on,
Yes,
drugs are
sir.
going
So
on.
there, yes, drugs, enteral feeding, then transfusions, if any, then electrolyte replacements, if any. So many things are there. Um, Definitely, it is not a integrated and automated system. It is manually integrated, and it is very prone to very much error. Many a times we have to correct it when we look into the nursing charts and our resident charts.
Is,
Many a times we find there is discrepancy.
is there an automated system anywhere? Are you able to go through anything like this? Is there a better
Sir,
way?
yes, sir. I have seen it in outside my institute and outside India, where they have these all whatever infusions are going, they are being charted in the electronic health record, and also according to the patient's temperature and all the insensible losses are also calculated. So
Electronic medical records, huh? They can enter it into the
yes,
electronic
yes, sir.
medical. All right.
Yes, sir.
Okay, great. So just finally, uh, what about Dr. Sulagna? Two questions. What about what percentage of ICUs actually, any idea, have beds which can weigh in Indian settings? Any idea? Did you come across any data? And about your ICU, are you having beds which can weigh?
Yes, sir. We have beds which can weigh around 30 to 40% of our beds are now having weights, weighing scales. India, sir, it will be very, if you consider all peripheral ICUs and all, I don't know the exact figure, but it will be less. It will
Yeah,
be
okay.
less.
Okay, the figures probably are not there only, I think. Yeah.
I mean, the INDICAP study had a lot of parameters, but it was done in 2011 and 12. So it is an old study. The INDICAP study had some, I don't remember actually. I mean, maybe
Okay.
they had
Yeah,
some
it's okay.
data on that.
Yeah.
Yeah.
The last question, what about artificial intelligence? So artificial intelligence has to come in, it's everywhere. Intensive care medicine journal, which is, the best journal for us in a way, is loaded with the artificial intelligence. So, and in
Yeah.
Stanford, they have used artificial intelligence to identify sepsis 24 hours before with better results. So you want to tell something, where are we going and how we can integrate? Because this has to go into electronic medical records integration. And
Yeah. So,
are you considering in your ICU?
sir, the first problem in our ICU is that we have not yet got complete electronic health monitoring systems. So without electronic health monitoring and without big data, it is difficult to form algorithms, form I mean to analyze those data and then form meaningful algorithms which can be used in our future patients. So we are yet to we are in the process of implementing and we will implement. So also in India, many we are having a lot of single-centered studies which are coming up with AI in various things like AI. We have one of our our fellows doing thesis on AI prediction of AKI in sepsis through machine learning. So there have been some work from our institute, but overall the quality of data will not improve unless we have prospective electronically recorded data. So that is one of the problems. And AI is now being used in every aspect of medical care, including critical care. So detection of sepsis, not just by clinical data, but also by different metabolomics, proteomics, and um, mainly so all these big
Omics.
data are being utilized. Omics, yeah. So those are utilized for sepsis diagnosis, sepsis prognosis, as well as I mean the help in clinical decision and in help in deciding on the intervention. So it is being if for institution, even for antibiotic policies and all, I mean deciding on the antibiotic policy. So every aspect of sepsis care, critical care is being covered by AI.
Yes, yeah,
And
absolutely. Yes, so absolutely. So I think AI is going to be there in a very big way, and we will have to adapt our ICUs and electronic health systems, health
so
records.
So, sir, so these when I mean already countries have done, they have done and they are doing. So when we have so many vital signs recording of so many patients in real time, so there is a huge data, and with those data we can arrive at very precise algorithms needed for, I mean, precision medicine. If we have to institute, then big data, machine learning, and AI is the answer. So we are going to. It's not just. It's not a guideline that we are going to follow in future. We are going to individualize every aspect of patient care in conditions like sepsis, septic shock, where we will precisely know how much blood pressure to target, how much fluid to be given, and so give from the initial vital parameters of the patient, we will be able to predict the clinical course and the response to treatment. So this is what is
Great,
coming.
great, Dr. Sulagana. I think you should take the lead, on Institute of Medical Sciences ICU in getting AI into our ICU, and then others can follow
Sir,
from there.
I mean, some projects have been conceived and it's in, we will try definitely.
Yeah, yeah, but it needs help from the administration also.
Yes, sir. Yes, sir.
Okay, okay, Dr. Sulagana, you want to say anything more?
Sir, I mean, I thought I was not very sure about whether I'll talk only about the vitals and all. So if anyone has any question, I can answer later also if anyone wants to send me any question.
Yeah,
I
yeah.
only
Okay.
one thing is important is that proper monitoring is very important, and especially when we shift the patients from ICU uh, for the next 3 days to 4 days. It is a critical time, and we should be very careful about the patients again deteriorating and needing ICU care. So, vital monitoring is very important.
Okay. Okay, Dr. Sulagana ma'am, thank you so much. It was wonderful
Thank
meeting
you,
you
sir.
and
Thank you,
hearing.
sir, for
Yeah.
this opportunity, and I'm really grateful to you. And I really will like to coordinate with you and your
Yes, yes,
channel.
definitely, ma'am. We will have more of you, and we will have more topics so the audience can learn from you and take benefit from your experience. Thank you, ma'am.
Thank you, sir. Thank you. Bye, sir.
Bye.